Hi guys, Dave O'Sullivan here again. Welcome to part 3 of 6 of the New Age Sports and Healthcare Professional series. And we're already on to the objective assessment today. So if you recall the 5 pillars of the New Age Sports Professional, and also the exact same system we use in private practice, no matter whether it's a professional athlete in that waiting room or whether it's a persistent pain patient or just an acute injury, we still use the exact same system. And that is the subjective assessment being pillar 1, pillar 2, which we're going to talk about today, objective assessment, pillar 3, the treatment or the intervention, pillar 4, the rehab or return to play system, and pillar 5, the resilience system. Okay, so pillar 2 today, objective assessment. Now, the biggest mistake that I made when I first started out, especially when I was working in pro sport at the time with Leeds Rhinos, was trying to make the diagnosis from the objective assessment and literally putting all my eggs into one basket, and basically almost believing what I thought I was seeing and going, right, that's it, I need to put this intervention in, or I need to put that. But as I step back over the years, and I've rehabbed a lot of professional athletes and also a lot of private practice patients and helped them get back to their lives successfully, the more I understood this stuff, the more I realized that actually all that we needed really was in the subjective history. And that's where last week, where we touched on the subjective, it's so important. But once we actually get to the objective, what we actually are looking for there then is broken down into 3 facets for my system. So what I like to do with the objective assessment now, or what I've shown a lot of sports physios, is I want you to ultimately have a bird's eye view of the person. So that first few minutes of the objective assessment, we're keeping an open mind. We're just looking at how the person's moving, and we're resisting that urge and that temptation to make the diagnosis within the first 2-3 minutes. Okay, and I'm still guilty of it sometimes, where I'll go, I'll see him do something and my mind's made up. Okay, and sometimes you can just waste a little bit of time going like that. So resist the urge, okay, and just look at the person's movement. Now, whether that's a generic movement, whether that's in walking, moving, doing specific tasks, checking their kind of movement strategies. And then what I like to do from there then is start to zone in a little bit. So then that could be something where we're maybe doing some form of passive assessment. Now, the value of a passive assessment is very underrated in my opinion, because we're getting an idea. First and foremost, we're getting an idea of how the person, the patient's responding to you. Are they able to actually relax when you're touching them? Now, that's going to be very important when we get to the next section and the next pillar, which is the treatment or intervention. So if someone, when I'm moving their leg and they're very nervous and they're holding a lot of tension, again, am I getting a real true value or true insight into this person? Or am I just getting a reaction that actually they're maybe not very comfortable with me at the moment? So is hands-on work going to be appropriate for them at this moment of time? Or is my time better spent doing maybe non-manual therapy techniques? So just keep that into consideration. But we can figure out from that what tissues are carrying protective tone. So once we've kind of got the patient to relax and we can have a feel of the movement of the tissues, we have to understand that it's not just muscles here, that there's skin, there's fascia, there's nerves, everything has to shorten and lengthen around 3 dimensions. Okay, so the fact of maybe using selective tension can be very useful, where we can see, okay, hip flexion's okay, but hip internal rotation may have some form of protective tone. So if hip flexion's okay, but hip internal rotation and supine is a little bit protective, for instance, then I would be very curious of how the protective tone, or maybe that adductor magnus tissue is. Okay, now if that has carrying protective tone, then okay, I'm going to just keep that into consideration. I'm going to resist the urge to go in and fix that, okay, straight away. But what I want to do is see how that relates back to the subjective assessment. So then we start to put this together a little bit, rather than just resisting the urge, going, okay, oh my God, I've got high protective tone at Dr. Magnus, I need to go in, I need to intervene, whether it's non-manual therapy techniques or actual putting my hands on the patient. But does it make sense to the subjective history? Okay, that's the second thing I look at. Then once we're pretty happy with the tissues that we feel are contributing to the pain output or the movement strategy, okay, that we want to influence positively, we then need to know what directions of force that the person may have lost confidence in. Okay, again, the work of the likes of Kylie Tucker, I keep referring back to her, especially in the mentorship. I'm a big fan of her work. Paul Hodges has shown it, that when the body has a noxious stimulus, we alter the direction of force going through the body. So what we want to do is try our best to find out which directions we need to restore and reassure. And once we have that, then we've got a very, very powerful piece of information then to really set us up for success on the next few pillars. Okay, I promise I'm not going to keep you long today. So just to recap that, my objective assessment is carrying on from my subjective assessment, and my findings, I will always go, okay, how does this make sense to the person's story? And then if I'm on the true kind of tissue that's maybe causing this protective tone in the first place, then I need to find, okay, what part of that tissue, because it may not be the muscle, it may be skin, it may be fascia carrying protective tone, it may be all three or all four. Then we need to find out what direction of force we want to restore and reassure. And once we have that, then I'm getting happy. Okay, that's going to make a big difference into what directions my force is with manual therapy, but also with non-manual therapy techniques. Okay, which parts of the muscle do I want to fire? Which is it, the proximal fibers? Is it the distal fibers? Which direction of force do I want to send through the body? So the body has to self-organize and work this thing out. Okay, so they're my three kind of facets for the objective assessment. But as I said, it starts first and foremost back with the subjective assessment. And once we're kind of confirming what we're finding, we're making sense of the subjective assessment in the objective, and that's setting me up for a great platform then for pillars 3, 4, and 5. Okay, so that's the week 3 of 6. I'm going keeping it a bit shorter today, and then once we have those tissues, and once we understand or we find some peripheral tissues that are contributing to this movement strategy or contributing to this pain output, that we have the ability to influence positively, either with our hands or with non-manual therapy techniques, then we're in a very, very good position. And I'm going to talk all about that then, how to influence that next week on the next installment of the New Age Sports and Private Practice Healthcare Professional series. Once again, my name is Dave O'Sullivan. Thank you for listening. Any questions, any comments, please let me know. I love reading all the comments. I love getting the emails. And as I said, I'll make my best effort to get back to you all.